Hello, friends of the Retina Channel podcast. Welcome to another episode of this series. Today, we have a study that's talking about complications of diabetic retinopathy. Today's author, Dr. Paul Micevych from University of California in San Francisco, will talk to us about risk factors in terms of individual risk factors or systemic risk factors that are associated with vitrectomy in diabetic retinopathy patients. So they have a retrospective study that compared patients who needed vitrectomy for complications of diabetic retinopathy and those patients who were matched but had PDR, proliferative diabetic retinopathy, but did not require vitrectomy. So they're using vitrectomy as a proxy, as Paul is saying, for advanced diabetic retinopathy. And they identified some interesting risk factors, and some of which are expected, but this study confirms what we already learning from other studies. And it also has some good suggestions in terms of what to do for these patients with proliferative diabetic retinopathy to reduce the risk of needing vitrectomy. Well, a little bit about Paul. He is a senior resident at the University of California, San Francisco. He did his undergraduate degree at Washington University in St. Louis in neuroscience. He did medical school at Northwestern University, and he will be doing a vitreoretinal surgery fellowship at University of Utah starting July. Congratulations to Paul for publishing this study and the achievements he has done so far, and I'm sure we'll be hearing from him in future years many times. Well, without further ado, let's start the conversation. Hello.
Hi, Dr. Kushan.
How are you, Paul?
I am good. How are you?
I'm good. Welcome to Retina Channel podcast.
Thank you. Appreciate you inviting me on the podcast today.
It's my pleasure. So, Dr. Micevych, as you know, this podcast is a journal club, and I was delighted to read your article in Ophthalmology Retina on risk factors and some associations you found on risk of progression to diabetic vitrectomy in your hospital in an urban setting. So I'm excited to talk to you about it. If that's okay with you, I'll just give a quick overview to the listeners, and then obviously you're the expert and we'll delve into the details with you. Is that okay?
That would be great.
Okay. So this is a retrospective study, and you looked at patients in sort of the sounds like a more of inner city type of population that you served, and then you looked over, I think, 222 patients. 111 of them was essentially your study arm, patients who needed diabetic vitrectomy for reasons we know, like vitreous hemorrhage and tractional retinal detachments, and I think neovascular glaucoma. And then you matched those patients who needed vitrectomy with similarly aged and diabetics. And then you looked at systemic risk factors and also personal risk factors regarding to the diabetic care. And you came to some interesting conclusions. More notably, lack of PRP would be one major risk factor leading to diabetic vitrectomy, which I think the way I looked at your article, to me, needing diabetic vitrectomy was like a surrogate for more advanced diabetes, like patients who would require more care and more advanced levels of diabetic retinopathy. So this is another review of things we know, and some of them you actually showed that are more risk factors for more advanced disease. So I would love to hear them from you. And first of all, what's the background of this study? You're a resident, as you know, hopefully interested in retina. I think you told me you're actually matching to a fellowship. Is that correct?
That's right. I'm in my last year of residency now, and planning to start Retina Fellowship in July at Moran in Utah. So
congratulations.
Thank you.
So tell us about what pushed you and your group to do this study, and let's go over the study in detail.
So, ultimately our group was really interested. We wanted to better understand what factors were leading to progression of patients who already had PDR. We just noticed within our population where we had a very high incidence of severe complications from PDR. Many were progressing to complications requiring vitrectomy. And so part of our big question was, are these individual patient-mediated factors that are leading to progression, or are they more systems-based issues that should be addressed in kind of a different way? So the way we structured the study was a case control, basically looking at, as you described exactly, the past 5 years of patients who had undergone diabetic vitrectomies for neovascular complications. And you're exactly right. We used vitrectomy as a proxy for basically end stage, not necessarily end stage, but complications from proliferative disease.
Yes.
And so we lumped what are somewhat heterogeneous complications, being, non-clearing hemorrhages, tractional detachments, and neovascular glaucoma together to sort of better increase our overall numbers and see if we could that could determine more strong conclusions, and then also subdivided our analyses by those groups. And as you pointed out, the primary results that we found were that the most significant variables actually were all modifiable, which was encouraging to us. So on the patient side, PRP was the most important factor, protective factor against vitrectomy. And from a systems perspective, we found sort of 3 other variables, one being just the simple treatment-naive interval from conversion of proliferative disease to the first treatment, be it VEGF or laser. Another being the time within the ophthalmology system, being that patients with us for not as long tended not to do as well. And then lastly, that loss to follow-up. And we looked at loss to follow-up in 3 different ways, both intervals of 3 months or more of missed visits, 6 months or more, or purely cumulative time beyond 3 months. And the way we did the study, it turns out they were all significant, so it probably didn't matter which way we did it. But with our multivariate model, we included the cumulative loss to follow-up.
So the systemic risk factors, they all sound to be like the same thing, essentially. If patients are with us, quicker with us, from time of diagnosis to time to treatment or some kind of intervention, they do better. And I noticed there was significant difference between those patients who needed vitrectomy and those who didn't. Like a major gap between the diagnosis and treatment. And that's probably because of loss of follow, I imagine. I mean, they were diagnosed and they're lost in the system until they came back somehow. And also time after that sounds to be important. That I think that matches with our experience, right? A lot of, unfortunately, patients with complicated diabetic retinopathy, and they have poor follow-up, right? So people who get lost.
That's exactly right. And in terms of loss to follow-up, we found every month of cumulative loss to follow-up within intervals of active PDR increased our odds of a vitrectomy or a complication requiring one by nearly 10%. So that was
that's very significant. So I mean, in other words, if someone is lost to follow-up after being diagnosed with PDR in matter of 10 months, less than a year, it's almost 100% they need some kind of vitrectomy intervention. I mean, this is obviously, I'm not a statistician, but we can say that if they're lost by about a year, the odds are they need some kind of major intervention. And then what other systemic risk factors were not associated with vitrectomy? Like what things you thought could be important? You have a big table. What were the important pertinent negatives, in other words?
Well, I think two that we were surprised by, I'll say. The first was we looked at the number of non-ophthalmology related visits in the intervals when patients were lost to follow-up, hoping that patients who followed up with their primary doctor, with their podiatrist, with their nephrologist, in the interim would bring them back to ophthalmology. We didn't see that. We didn't see a relationship there.
Yes.
And another one was that we didn't see a significant difference in the delay between our screening. In our system here, we have sort of a telescreening pathway to bring patients into our care, as well as more traditional pathways of being seen first by the optometrist or other providers. We didn't see a significant delay there either. So I would say those two things were surprising. We thought perhaps those would be areas for us to target as weaknesses, but not necessarily the case.
Okay. So I think as a system-based approach, what we can do as physicians and healthcare providers is to increase their exposure to ophthalmology and make sure the follow-ups are maintained, which is always a challenge, obviously. But maybe when someone has PDR, we can ask our staff to follow with them more, more promptly and maybe have more repeated requests for follow-up.
Yeah, and we that sort of leads right into, we took the results from this study to ask ourselves, what can we do to create some sort of an initiative to fill these gaps? And presuming loss to follow-up and PRP are the two most modifiable variables there. Those were sort of the arms of our intervention. So we've since sort of opened up a new PRP only laser clinic staffed by the residents, as well as a high-risk patient registry for all patients with a new diagnosis of PDR that are sort of, we have a staff member designated to call them, remind them of appointments, reschedule missed appointments until they achieve the goal of PRP, and then they're removed from said list.
Interesting. So you've made a point to address these two things you identified. One is the PRP as a protective factor. One is better follow-up as a protective factor. Interesting. Very nice.
We're hopeful that will be promising as a possibility.
Very good. So going back to individual risk factors, you mentioned PRP as a protective factor. What were other things? I noticed in your table you had some like age, younger age being a risk factor. I always knew when we know that older people are somehow protected, and that your study shows that as well. What are the other things that were risk factors for needing vitrectomy?
Well, unfortunately, the only one that with our multivariate model sort of stood up with all of these systemic variables included was PRP. That's not to say that none of these individual variables are related. There's a reason we looked at all of them. It's because, of course, many studies have shown that a lot of these variables are involved. Yeah. I think it's challenging when you're in a multivariate model with very big factors like loss to follow-up and time within the ophthalmology system that can outweigh smaller effects.
Yes.
I think there likely were
for the viewers and listeners, mention some of the things you looked at. You looked at a lot of things, right? So
that's right.
Sex, which eye, type 1 or type 2 diabetes, the language, English being the primary or your secondary language, race, ethnicity, history of homelessness or incarceration, very interesting things you looked at. And I think one of the univariate study showed history of homelessness being a risk factor, but the multivariate didn't show that.
That's right.
Insurance status was one thing you looked at, and it wasn't very consistent. The solid thing was presence of PRP as a protective factor. You also looked at the partial PRP, and I think that was only partially protective. Could you explain that for me, please?
Of course. So we did also look at patients who had what we deemed complete PRP versus partial PRP, which was basically just a definition of whether or not it was 360 PRP without notation of room for fill-in or blockage from hemorrhage or from cataract, things like that. So not a quantitative note of completeness, but more of a overall physician's sense of the laser.
Okay, and partial PRP protective still or no?
We did find that it was protective to have partial PRP versus full, but not within our multivariate model. It was trending towards significance. I believe our p-value was about 0.07 in that one. So, clear benefit there, but likely a little underpowered.
Makes sense. And it makes sense. Okay. All right. So, and there was in this podcast, actually, we had another article right after protocol S came out. A lot of us started to treat all these PDR patients with anti-VEGF, myself included. And over time, more studies came out, and we saw there's a lot of follow-up that is lost. NVG being a factor, and your study kind of confirms that maybe we still need PRP for some subset of patients. You have an inner city population that sounds like PRP is a must. I'm not sure if it extends to all patients, but for me, personally, I essentially doing PRP on everyone, in addition to some anti-VEGF. So you mentioned you have a clinic that's just PRP clinic for this. Very interesting for these patients. One question I have, Dr. Micevych, how did you come up with the control group? I think that's very critical because obviously your study arm is clear, people who have vitrectomy because of diabetic complications. But how do you match that with other people who would?
I think that, as a case control study, control selection, as you know, is probably the most challenging part of it. And so picking those subjects was something we thought a lot about. We basically identified patients with PDR, CPT codes. But the challenging part, because we wanted to stage match them. So we wanted patients who also had proliferative disease, of course. But the more nuanced thing to it was that we used incidence density sampling to identify patients that were also calendar matched. So we wanted to account for variables within things that we weren't thinking about to try and control. So for example, a patient who had vitrectomy on August 20th of 2020, we wanted to identify a patient who was seen in clinic on that exact same date as well. And so through doing that, we hopefully helped account for various differences by month, by year, of course, with the pandemic and factors like that could have impacted the results as well.
I guess age matched, obviously. Duration of diabetes was matched, I imagine, but those, or A1C was matched, all those things that you try to have the same people who just didn't have. Okay.
Yes, and we didn't have any differences in our groups in those metrics either.
Okay. Must have taken some time. I mean, I think it's very hard, as you said, finding the control group in these type of studies is very challenging. It really that's very, very difficult. So congratulations.
Well, thank you. Appreciate it.
Okay. So what do you want us to learn from your study? You mentioned that already. So if in 2 years from today, if I think about Dr. Paul Micevych and his study and his group study, what do I want to remember about treating these patients?
Well, I think the first takeaway is, we have to treat the patient in front of us, not just a protocol or a pathway. And so patients for whom they seem very high risk for loss to follow-up in management of PDR, I think PRP has to be a part of the treatment. That's not to say that many of the patients in this study and all of them did receive VEGF, and that is a part of our pathway as well as bridge therapy, but VEGF monotherapy may not be the best option for patients for whom you're very worried about loss to follow-up. I think the other big takeaway is that quality improvement initiatives for similar type safety net hospital systems for the goal of improving care, patients with PDR should think about improving access to PRP, as well as reducing loss to follow-up in intervals of active PDR.
And one thing that I think was very interesting, time that they start seeing ophthalmology, that seems to be a major gap in that system. Very good. Well, thank you very much, Paul. I really appreciate your time. Congratulations on your study and also entering Retina, and wish you all the best. And I hope I see you in the future in one of the meetings and read more about your articles.
Absolutely. Well, thank you for having me on the podcast.
Cheers. Well, folks, this wraps up episode 77 of the Retina Channel podcast. Thank you for listening to this episode or watching this episode. And I want to thank Dr. Micevych again for coming to the show and talking to us about his nice article about the risk factors for diabetic vitrectomy. Well, a bit of a heads up about our next episode. Dr. Arthur Sitt will be our guest next time. And he will talk about the study that's a mix of glaucoma and retina. He will talk about the association of the scleral buckle on the outflow tract of aqueous humor, and association of elevation of intraocular pressure and presence of a scleral buckle. It's an interesting article published in Ophthalmology Glaucoma, and I look forward to chatting with Dr. Sid about this article. Until then, be well, take care, and we'll see you later.